the last video we asked how long you should leave the catheter in place. Frustratingly, the evidence for how long you should leave it in place is very conflicting. And rather than have a really set time frame, we would probably look at a number of factors that influence our decision. In particular, we need to see the azotemia and the electrolytes, so any biochemical abnormalities, they need to have resolved. Otherwise, I would keep the catheter in place. I would also watch for post-obstructive diuresis. Often these caps, as soon as you unblock them, will become very PUPD, and we need to match the ins and outs and make sure that they are adequate with their fluid status. The other thing that influences my decision is what the urine looked like at the time I unblocked the cat. So was it really hemorrhagic? Was there a lot of sediment? Am I concerned that actually if I remove the catheter too quickly, the cat will quickly reblock because there's so much material in the urine? And if I can, I will often wait 24, 48 hours, even sort of 72 hours, so that the urine is starting to look more normal. What we have to bear in mind is if we leave the catheter in place, we're also causing a degree of iatrogenic damage, and so the urine will eventually become hemorrhagic because of the catheter. So we have to try and find that sort of sweet spot where we're helping the situation and not contributing to it. The other thing would be practical considerations about where the cat is staying. Is it at an out-of-hour provider? And if we remove the catheter, when is he most likely to reobstruct and could need potential vet intervention? So often I will remove it sort of at the very end of the day so that there should be no need to urinate overnight, and then staff would be available in the morning so that if there was a problem, we can manage the cat and the patient. So all these factors would feed in to when I decide to remove the catheter. And with that, I'm going to hand over to Lee.
Great. So one of the things to discuss then is that some of these cats, unfortunately, will just continue to reblock, or there'll be some physical cause of the blockage that you won't be able to manage medically. And these are the sorts of cases that we'll consider for surgery. So the general surgical procedure that we'll do is a perineal urophrostomie, but it's really important to know that this won't resolve the clinical signs of dysuria and so on, because the cats fundamentally will have cystitis, and doing a PU won't get rid of the cystitis, but it will enable them to urinate and get rid of the blockage. So as I say, really the indications are either a stricture, a calculus that you're unable to flush back into the bladder, or some sort of iatrogenic urethral damage. So for example, a catheter has perforated the urethra and there's a leakage going on that's distal enough that a perineal urophrostomie will get above it. So in terms of the actual technique, it is a little bit fiddly, and so I'd probably suggest either trying to watch someone do one or have someone scrubbed in with you to help you if you've not done one before. So we're generally going to position the cats in sternal recumbency. So we're going to have them on their tummy with the back legs hanging off the back of the table, and we're going to pull the tail forwards, and usually we just towel clip that onto the scruff of the neck or something to keep it out of the way. You need a fairly wide clip and prep, so we do need to clean the whole area around the perineum and the anus. And then we usually put a purse string in the anus just to prevent fecal contamination during surgery. One of the things that makes the surgery much easier is if you're able to get a catheter into the urethra before you start. And so one of the first things we'll do in theatre is place a urethral catheter. If that's not possible because there's a calculus, for example, or a stricture that you can't get past, it's still possible to do the surgery, but you have to be much more careful later on when you're incising into the urethra not to cause further damage. So the start of the surgery is just going to be an elliptical incision. So we're going to cut all the way around the penis and scrotum, because essentially that's all going to be removed as part of the surgery. So usually if you hold the remnants of the scrotum and the penis in your hand, there's a little sort of crease, and you just cut in that crease, and that'll be about the right amount of tension when you come to close. Once we've done that, we're going to continue our dissection up, staying as close as possible to the penis. And so there'll be various different ligaments and muscles that we'll have to cut. So as you start to dissect forward, initially there'll just be some fascia on the ventral part of the penis, and you can just blunt dissect through that. You're then going to come across the ischiocavernosus muscles, and they're going to be at roughly the 4 and 8 o'clock positions. And those ones you're going to have to cut, and that's what holds the penis onto the pubis and onto the pelvis. So you're going to have to cut through those. Just be a little bit careful when you're doing this because there is a blood vessel just in front of the muscle, and so you don't want to cut too far cranially. So just nibble away at the muscle with your scissors or bipolar cautery if you've got it. And then as you get through to the front of the muscle, suddenly everything will pull backwards. So throughout this whole part of the procedure, we've usually got an Alice tissue forceps or something on the penis just so we can manipulate it. Once we've done that, we're then going to have to remove the retractor penis muscle. So I've got some photos going through all this now. So this is just cutting the ischiocavenosus muscles that we talked about. So you can see here, this one's at the 4 o'clock position. And we're just doing that with bipolar cautery in this photo. We're then going to carry on cutting up, and then this photo is just showing removal of the retractor penis muscle. So in neutered males, this muscle's really, really thin. It's not that obvious. So don't worry too much if you can't see an obvious muscle, but there should be a little ligament or bit of fascia on the dorsal part of the penis that you can just trim off. Once you've done this, ideally you would have your catheter in place. And you can see now we've dissected out the whole penis. And you want to make sure this dissection continues as far as you can, up to the level of the bulbourethral glands. So in this photo, you can hopefully see at the base of the penis, there's 2 sort of pink fleshy sacs around the 11 o'clock and 1 o'clock position. And those are the bulbourethral glands. So that's how we know we've gone far enough cranially that we can then stop our penile dissection. At this point, we need to do a cut into the penis, into the urethra, and we're going to cut down onto our catheter with an 11 blade, and then we're just going to extend the incision forwards using some straight iris scissors just to make sure we've got a really clean cut. To make sure you've gone far enough forward, we're then going to insert an artery forceps, and that's what we're doing in the photo here. And you should be able to get a mosquito forceps all the way up to the box hinge, as you can see in the photo. And that should be roughly the level of the bulbourethral glands, and that's how you know you've gone far enough forwards. Because the urethra is nice and wide at this point, you're removing all the narrow penile urethra. At this point, we're going to start our suturing. So typically I would use 4/0 or 5/0 monocryl or equivalent. And initially we're going to place sutures at around the 10 and 2 o'clock position. And that's where we're holding the urethral wall here with the forceps. And those are really the key sutures because they're going to hold the urethra open, and you can see that nice wide urethra on the photo, and that's what we're aiming for at the end of the surgery. So I would normally place the 10 and 2 o'clock sutures separately as 2 simple interrupted sutures, and then run a continuous suture down each side. So there was a study looking at continuous versus interrupted sutures, and there was no difference in terms of outcome. And equally, using absorbable versus non-absorbable suture, again, no difference in outcome. So I would use monocryl for these because it's quite rapidly absorbent, and I would just do each side in 1 continuous suture. And that will ensure you get a much better seal between the urethral wall and the skin. When we're doing these sutures, you want to make sure you take really shallow, narrow bites of the skin because we want to get really, really good apposition between the urethral mucosa and the skin just to ensure we get a rapid seal and rapid healing across. When you've done that, there'll usually be a little bit of skin to close at the top, and that can just be some normal skin sutures. So normally I'd use something like Effilon or nylon for that. And then you'll just need to ligate the penis at the bottom and amputate it, and then suture close the skin over the amputated part of the penis. And we're going for roughly a 1 to 2 centimetre drainage board, which is shown in the photo, and that will hopefully reduce the rate of urine damage to the skin. So hopefully it all goes smoothly, but there are some complications that we can see. So we can see recurrent stricture or stenosis, and that's typically because people haven't gone far enough forward. So they've not got up to the level of the bulbourethral glands and not got to that really wide intrapelvic part of the urethra. The other thing that can happen is you can get UTIs and surgical site infections, and the UTIs are really just because you've now got a much shorter, wider urethra, so it's a bit more like a female urethra than a male one, which we started with. We can get dehiscence, that's particularly if you've got urine leakage, or that can cause urine leakage and subcutaneous collection of urine, which can then cause dehiscence, and that can lead to stricture and surgical site infections and so on. We sometimes will see some bleeding, although that's not as common in cats as dog urophrostomies, and urine scald I've already mentioned if the drainage board isn't big enough. And then recurrent obstructions really would just be if you've not got rid of the underlying cause. So you've got something like a urolith, or you've had something like a dehiscence and a stricture. And if you do get a really bad stricture, unfortunately, it is a case of then doing revision surgery, and that can be quite challenging because you've not got much urethra left. So we would normally try and redo the perineal urothrostomy, but ultimately that might not be possible and you might have to do a higher up urothrostomy. So the other urothrostomies that are described are doing prepubic, transpubic, where it goes through the pubic bone, and subpubic, where it's in front of the pubic bone. But these really are salvage procedures, and if you can do a perineal urothrostomy, that would always be preferable. They have a much higher risk of complications and also a poorer quality of life, just because they can be incontinent and they're much more prone to having UTIs. So really we've reserved these for the really difficult cases where a PU wouldn't be possible. So that brings us to the end of the blocked cat lecture. Hopefully you found this really useful, and there'll be more lectures on blocked dogs coming up in the near future.